pericholecystic fluid. The wall thickness of a normal gallbladder is less than 3 millimeters. The gallbladder wall thickness is going to be best measured anteriorly where there is a liver-gallbladder interface. Avoid measuring posteriorly since the wall borders of the gallbladder can be hard to define against the adjacent bowel. You can see that on both the sagittal as well as on the transverse view that it would be hard to obtain a measurement posteriorly. So stick with measuring the gallbladder wall anteriorly. Gallbladder wall thickening is a nonspecific finding and can be due to multiple biliary as well as non-biliary causes. The presence of wall thickening cannot be used to make the diagnosis of cholecystitis alone. If you look at the differential here, it ranges from cholecystitis to adenomyomatosis to cancer to AIDS cholangiopathy to hepatitis, pancreatitis, congestive heart failure, cirrhosis, and hypoproteinemia. Now this patient on the sagittal view here, you can note has marked gallbladder wall thickening. Due to the marked wall thickening, note the presence of the heterogeneous appearance of the wall due to edema. You do not see any gallstones within the lumen. The lumen is anechoic. You can see a nice anechoic lumen right here. On the transverse view, you can also again appreciate the marked wall thickness and thickening and the heterogeneous appearance. This was a patient who had no acute biliary disease. This patient had cancer with severe hypoproteinemia, ascites, and sepsis. The wall thickening was non-biliary in this patient. This patient here has underlying cirrhosis. You can see the nodular appearance of the liver. You can see the ascites surrounding the liver. Note that the gallbladder wall here is markedly thickened. The wall thickening in this patient is due to his liver disease and not acute biliary disease. So remember, this is a non-specific finding. Adenomyomatosis is characterized by mucosal hyperplasia and thickening of the muscular layer of the gallbladder. And you can see that here. The result is either diffuse or focal wall thickening, mucosal herniation into the muscular layer. These are called Rokitansky-Aschoff sinuses, and they frequently contain cholesterol crystals. And you can see here, you've got echogenic foci with short comet tails posterior to it. On this sagittal view of the gallbladder, note the focal gallbladder wall thickening of the fundus. Cholesterol crystals, however, are not definitively seen in this case. When focal wall thickening is present and no cholesterol crystals are seen, then other differential diagnoses need to be considered. It's beyond the scope of this focused gallbladder series to get into that. But remember, focal wall thickening without the presence of cholesterol crystals warrants a more comprehensive ultrasound examination. Diffuse wall thickening is noted in this patient without active biliary disease, but note the focal thickening near the fundus. You can see cholesterol crystals with short posterior comet tails, consistent with the diagnosis of adenomyomatosis. You can also see that on the transverse view here. You can see the cholesterol crystals and these short comet tails posterior. The presence of pericholecystic fluid is a nonspecific finding, and it often occurs secondary to localized inflammation from other causes. Two specific patterns of pericholecystic fluid have been described. Type 1 is a thin anechoic crescent-shaped collection like you see here adjacent to the gallbladder wall. This is thought to be a nonspecific finding. Type 2 is a round or irregularly shaped fluid collection with thick walls, septations, or internal debris, and when found adjacent to the gallbladder, this is more likely to be associated with gallbladder wall perforation and abscess formation. This patient did have cholecystitis and had a very small rim of free fluid surrounding the gallbladder that was due to localized gallbladder wall perforation. Here we have a transverse scan of a patient with cholecystitis due to an impacted stone in the neck. Note the small amount of simple free fluid at the 9 o'clock position right here. Note that you can see the triangular corners of the free fluid as it butts against surrounding structures. Remember, just like in the trauma section we discussed, fluid is formless and shapeless and has to take the shape of the container that it's in. This pericholecystic fluid was biliary in etiology and the result of localized gallbladder wall perforation. Now here we have a sagittal view of a gallbladder in a patient with acute cholecystitis. You can see that there's marked wall thickening here. You can see that the wall thickening is not homogeneous in appearance, that it's heterogeneous, and that there's some linear areas that are hypoechoic. You want to make sure you don't call this pericholecystic fluid. Look for presence of wall on either side, or of a wall on either side of these hypoechoic areas. But notice here, down by the neck, that there's a small triangular wedge of fluid abutting up against the liver. There's no wall surrounding it. It has triangular corners. So this is consistent with pericholecystic fluid. You can see the multiple gallstones within the lumen. Here's an impacted stone in the neck. You can see also the presence of some echogenic foci here and some short comet tails. This is due to adenomyomatosis. But note that this patient has both wall thickening and free fluid. So perforation occurs in up to 10% of patients who have acute cholecystitis. Most often this is in association with gangrenous cholecystitis. The fundus is going to be the most common site because it has the least blood supply. Subacute perforation typically leads to pericholecystic abscess formation. These abscess formations can occur within the gallbladder wall or adjacent to the wall in the gallbladder fossa. These fluid collections are complex and will contain internal echoes. This was an elderly woman who was aphasic, who had been having anorexia and malaise for several weeks, was brought in febrile with a rigid abdomen. She had long-standing cholecystitis, and she had development of a gallbladder or a pericholecystic abscess here. You can see this complex fluid collection within the wall, and there was some free fluid surrounding the gallbladder here. So she underwent emergent cholecystectomy and was also found to have gangrenous changes on her path report. So let's review the key points before concluding. Wall thickening is a nonspecific finding. Pericholecystic is a nonspecific finding and can be due to biliary as well as non-biliary causes. Adenomyomatosis produces diffuse or focal wall thickening, and cholesterol crystals are frequently visualized. And lastly, pericholecystic abscess formation is the result of gallbladder wall perforation. I'm Dr. Robert Jones, and welcome to the Assessing the Gallbladder Common Bile Duct lecture. Although evaluation of the CBD is not included as part of the intro gallbladder module, a brief intro to evaluation of the CBD is provided, since attempts to visualize the CBD should be made on all the gallbladder exams you perform. Developing proficiency in the evaluation of the CBD has a much longer learning curve, so practice should be initiated early. The common bile duct courses inferior and medial as it approaches the duodenum. The normal common bile duct is less than 7 millimeters, and that's measured inner wall to inner wall. And in patients who are post-cholecystectomy, they can have common bile ducts with a diameter up to 1 centimeter. It has also been suggested that the common bile duct can be up to 1 millimeter per decade of life for patients over 70. This would mean the CBD could be up to 9 millimeters normally in a 90-year-old patient. Okay, to perform the common bile duct exam, you want to place the patient in the left lateral decubitus position with the transducer caudal to the right costal margin at the midclavicular line, with the transducer plane perpendicular to the costal margin. So the costal margin runs like this, so you're going to have the transducer perpendicular. The gallbladder is identified in the sagittal plane, and then the transducer is gently angled to the patient's right so that the portal vein is seen in its long axis. The common bile duct is going to be found anterior to the portal vein. Here's a sagittal view of the common bile duct, so anterior, posterior, head, foot. You have the inferior vena cava posterior here. You have the portal vein here, and then anterior to that you have the common bile duct. Here you have a normal common bile duct. It measures 2.99 millimeters, which is normal. Posterior to that you have the portal vein, and you can see the common bile duct here in a sagittal plane. Here you have a dilated common bile duct. It measures greater than 7 millimeters, and here you've got posterior to it the portal vein. On the video clip following it distally, you can see that there is a stone present with clean posterior shadowing. This was a patient who had choledocholithiasis. However, note that common bile duct stones are infrequently visualized with ultrasound, and the diagnosis of choledocholithiasis is suggested with ultrasound based on the presence of gallstones, tenderness, and a dilated common bile duct. Here's a patient here who has a common bile duct visualized here. You can see an echogenic foci within there that is due to the presence of a small common bile duct stone. You can see the portal vein posterior to it, and here you can see the inferior vena cava. You can see the gallbladder here, and you can see gallstones present within the gallbladder. This common bile duct measured approximately 6 millimeters, so it was not dilated, but here you have a stone directly visualized within the common bile duct. Here you have a sagittal view of the gallbladder here. So anterior, posterior, head, and foot. You can see the gallbladder in its sagittal plane right here. By moving the transducer a little bit towards the patient's right, we can now see the common bile duct here, and you can see some echogenic foci within there. This patient had choledocholithiasis and had several stones present within the common bile duct. So remember, in order to visualize the common bile duct, you're going to have to use very subtle angulations and movements of the transducer. This concludes the assessing the common bile duct video. So remember, try on every gallbladder scan you do to attempt to find the common bile duct. It's not going to be easy at first, and it's going to take time, but it's an essential part of the gallbladder ultrasound exam.